Hello, welcome everyone, and thank you for joining us virtually as a part of the Medicaid competency-based training series for long-term services and supports. This recording is of an introduction to behavior support plan development. This training was recorded on August 31st, 2022, and will be maintained on the DHS website as a training available to LTSS professionals. Iowa Medicaid is implementing the competency-based training and technical assistance across the state to build positive outcomes for members and providers, understand state and federal regulations, and increase access to free training for direct support professionals. Please feel free to complete this pretest to allow us to understand a baseline of knowledge in this topic area. To receive a certificate of completion for this training, please complete the competency-based test at the end of this training through the link or the QR code provided. We also welcome feedback to this training and process through a post-attendee survey that will be available at the end of this training. Today we have Susan Smith with ITABS, licensed clinical rehabilitation counselor and applied behavior analyst, to help us navigate developing behavior support or behavior intervention plans. Thank you, Susan.
Thank you. And thank you for everybody for joining. I know that behavior support plan development is probably a topic that everybody's just really interested in hearing more about. So I'm glad that you joined. So I want to say first that the BSP, as it's sometimes called, in different environments, it is going to include different things. There's a whole lot of things that BSP can include, and in some environments, some of those things are split out into different documents, but collectively they're part of the BSP. So keep that in mind, that it's a very broad term. I want to say that when I write an ITABS BSP, I typically try to keep the information that's really relevant to direct support professionals in the BSP, and the other information, historical information, and so forth, is kept in other places. I try to limit it to one piece of paper, front and back, but once in a while I break my own rule and include a lot more than that. I also think it's really important to keep the language simple. I've heard the Department of Justice even make reference to like a 6th grade level. We have direct support staff who, for which English is not their first language. So we want to keep it at a language that everybody that's going to be using the document can use it, can understand it. And if I do include technical information or technical terminology, I try to pair that with everyday language. And again, I've broken my own rule in that sometimes, but I really strive for it. And that's what I would encourage you to do at this point as well. So let's look at the objectives. We're going to describe the purpose of a functional assessment. And we're going to look at the difference between proactive and reactive interventions. We're going to have at least 3 reasons that restrictive procedures should not be used any more than necessary, and also describe a system of developing behavior intervention plans that are based in positive behavior supports and are reflective of functional assessment. Next slide. So the words that I haven't read are typically like the headings that I would use in an ITABS BSP. A lot of times in this field of service, I think that we have focused a lot more on goals than we have on values. So I think it's good to talk about them because they can both be very helpful in a behavior support plan. A value is something that goes on and is never completed. Some examples are being a loving parent, or sometimes I use the example of being a good daughter for my parents. I can try to do things every single day and I never get that completely accomplished. It goes on. And that's different from a goal. That's usually an objective, which supports a value. A goal is something that can be completed. It can be chalked off the list. Like if I was trying to attend work 5 days in a row, or if my goal was to get my living room painted, when it's done, I can cross it off. But that value of being a good daughter or trying to be likable or lovable is something that I can do every day and it never finishes. So I think it's important that we know that. One of the reasons I think this is valuable in behavior support plan development is that there are some people who are not real motivated to do things because of other people's values. And what I mean by that is if I were a staff and I was just saying, you need to do this, or you should do this, or this is appropriate or not appropriate, those are all my values or society's values. And for a lot of people, they will make that the difference, but some they won't. And so when we identify what the person's values and longer term goals are, then we can use that to motivate them. And it might sound like something like this. I know you're really interested in having more alone time or more independence. What can I help you do right now that's going to help get you closer to that value? Or what's a choice you can make right now that's going to, help you work toward that? Notice I never said it was a good idea or a bad idea about what they were working toward, but I linked it with their value, and that can make a huge difference. Next slide. Okay, so strengths are another thing that we should consider for several reasons. It's part of person-centered planning, which I think everyone in HCBS services is striving for these days. It can also help us spark an idea of how the person's strength can help overcome a challenging behavior. For instance, like if we know somebody is able to follow a checklist, that might be a good way to help them go through the steps of, say, cleaning their room, or follow a hygiene routine, before they go to work or at bed at night. So we can look at those and we can use those strengths to help them work toward the things that are in their best interest and the things that they value. And also, I think it's just a good idea for the staff and people reading the BSP to know that there's a lot more to the person than the challenging behaviors they're exhibiting. They also have some strengths that we want to keep in mind and compliment them for those strengths when they occur. Next. So behaviors, I want to start by saying, talking just a little bit about terminology here. In this presentation, I use the term behaviors that interfere with the person's goals or value. I want to say there's a lot of variation depending on who's writing the behavior support plan. I have seen things like interfering behaviors. I've seen ineffective behaviors. I think if you were to read any like professional literature or book chapters, you're going to see terms like target behavior or maladaptive behavior. I know at the state resource centers, when I've worked in the psychology department there, their BSPs use the term behaviors of concern. And again, I think that term was identified around 2005 when the Department of Justice was there. So that's a term that stuck around for a long time. It's everyday language that everybody can understand. So what's important to know about the behavior when you're defining it in the behavior support plan is that we use what's called an operational definition. And what that means is it is so clear that if 10 different people had read the definition and they were making an observation of the person, would they all agree whether or not it happened? And some examples would be like for aggression to other people, might define it as hitting, kicking, or biting. So in a definition for aggression, hitting, kicking, or biting, and sometimes it's very valuable to put what the behavior does not include, especially if it's something that could be confusing. So in this example here, does not include a strong high five. Maybe this person has a history of giving that high five so hard that some people are misinterpreting that and counting that as aggression. So you want to, and they have completely different functions, they happen in different contexts. So you want to separate that out. Some examples of definitions of behaviors that, might be too vague would be things like does not accept no, or is not respectful. Well, I think we all have a different idea of what respectful is. So we would probably get data that's all over the places if we defined it like that. So we would want, if we had a concern with respect, then we would want to define exactly, what it is that we're talking about. Next slide. So the next thing we want to talk about is functional assessment results. And The purpose of functional assessment, and I think you're going to want to listen close to this one, is to identify those contexts and antecedents and also the consequences that surround the behavior. And sometimes in my behavior support plans, I put it in a table like this. And I want to clarify that that word consequence is a technical term, and sometimes it's unfortunate because it's misinterpreted by most everyone who looks at it. Consequence isn't intended to mean like a punishment, which is what most people would understandably would think, but it comes from the world of behavior analysis. And what it means is the way the environment changes or the way things change for the person immediately following the behavior. So it could mean that they gained something that they didn't have before the behavior happened, or that they avoided something or escaped something, but it's the way things change for them afterwards. And the context and antecedents, I should say too, is the two examples we have today are pretty simple to get the point home and to stay within our time frame. But those can be things that happened a long time ago, like in early childhood, things that still influences the person's behavior. Or they could be things that happened literally a second before the behavior happened. And in behavior analysis, we kind of have different ways to separate those out. I think for this, and for behavior analysts, that might be important to think about the differences. But for the most readers of the BSP, just having one column there and calling it context or antecedents is sufficient. So we're going to look at two examples here. This first one is someone called David, and I think this is actually a consultation I did, I think in a skilled nursing facility. David was someone who was not mobile and required a lot of staff assistance to transfer. And so that was the behavior, is that he was pinching staff's arms and forehands. And the consequence or the antecedents for that is anytime he is being transferred between his bed, the chair, the toilet, wheelchair. And so that's when it happened. And the consequences, or what changed, is staff continued doing the transfer. They could not stop. You can't put somebody, on a toilet and then never go back and get them again because they don't like the transfer. So, we think that probably his intention was trying to get people to stop, but it kept going. So let's go to the next slide now and look at the next person who we're going to refer to as John. John's situation was completely different. He also was living in a congregate setting. His behaviors were vocal and physical aggression. He had language developed, so he could call people names and swear up a storm. He could throw items, and he often refused showers. So some of the antecedents or contexts in which those behaviors happened, were he felt like other people made decisions for him and that they didn't treat him with respect, that they treated him like a child. Sometimes when the environment got too stimulating, when there was a lot of noise or a lot of people walking around, and also when he was asked to change his clothes, he would not only refuse to do that, but he would refuse to take a shower as well. And so how did we think things changed for him after the behavior happened? Well, he escaped some uncomfortable feelings. He felt retaliation. If they're going to treat me like that, I can treat them like that too. And he felt so more powerful, like he had more control again. And getting people to move away from him when he didn't shower, not a lot for several days, people didn't want to sit close to him and he didn't want to change his clothes. So that would be how I might put the functional assessment results into a BSP. Next slide, please. So let's talk a little bit about functional assessment. There are 3 different types, or sometimes they're referred to as levels. The first one, and they all have pros and cons. So there is not a perfect one that's perfect for all situations or for all behaviors. Sometimes we have to pick and choose. Sometimes we start with one, and if it doesn't yield adequate results, we go on to the next one. But the first type is called indirect results or indirect analysis. And examples would be like an interview. It might be like a manager interviewing direct care staff, or a psychologist or a behavior analyst. Sometimes it's just a free interview where they're asking random questions. Sometimes it is a piece of paper and pencil that asks questions and they're answering those. Sometimes it's rating scales or a questionnaire. I put some examples here in ways that I think that if you wanted to Google them and find copies of them, you can the first three. You can find those online. They are not copyrighted, so you can use them. There's another one called the QABF, Questions About Behavior Function. I don't know that you can find that online, but it's commonly used as well. The last one, behavior chain analysis, is something that's often used in a therapy setting. And it's a little bit different from those first three in that the first three we're often going to have like a staff or a parent, someone who knows the person well, is going to be providing information. Where in the behavior chain analysis, it's more developed for people who have language, and the individual themselves would be providing information for it. So one thing about indirect analysis is that while they're very easy to use and like the first three really don't require a lot of training, anybody can read the sentence and answer, yes or no to it, is that the accuracy is not as good either. So there's a payoff. So a lot of times it's a good place to start to see what you get. Sometimes you get some answers from the staff or the parents that know the person well that lead you to somewhere else that you want to dig into further. So let's go to the next slide. So here is an example of the behavior chain analysis. And this is a homemade version that I've made. And actually, I have various versions. I have one that has a larger number of circles on there. It was developed specifically for people who had had a lot of early adversity in their life, sometimes like trauma or a childhood that was less than desirable. So this is only one example. It can be used in a therapy setting. It can be used in a debriefing setting. If there is someone like a manager that has a good relationship with the person, they could kind of use this to talk through with the person, what happened. And then that person, if they see a therapist, they could take it with to the therapist. I've had people who had a manila envelope and they put them all in there in between therapy sessions and take them with. Sometimes laying those out on the therapy table and that the therapist can look at them is easier for the person to participate if they don't feel like somebody's looking across the desk from them, drilling them with, what happened, how are things going? Because now they have this visual. It's kind of like a barrier between them and they feel protected and they can talk a lot more. Sometimes it's interesting to have staff fill one out. How do you think the person was feeling? What do you think they felt like they gained from it? And then kind of make a comparison between that and what the individual reports. And sometimes that can yield some helpful information as well. I do happen to have, I think maybe this might have been in one of your handouts, but I have a PowerPoint that has a few extra slides that kind of describe more and give some more information. If that's something you're interested in, you can either put that in the survey or you can send me an email directly and I would send that to you if you have interest. Okay, next slide. So those are all pertaining to indirect sources of functional assessment because we're just talking to people, getting their opinion about what happened. The next type is called descriptive analysis, and that's where there's somebody who's made an observation of the behavior in relationship to the events that are changed. So what that means is they've just observed it. They weren't trying to make therapeutic interventions during the behavior. Sometimes it's called ABC recording. So you're just sitting there watching to see what happens. Or if you were there when it happens, you can record immediately afterwards. Again, pros and cons, you have to interpret the results cautiously because it can easily be biased by what the person's recording. Sometimes I can see just in the choice of words that they use that there's a clear bias. When they use words like had a fit or, various things, I can just kind of hear that their mind was already made up on what happened. And the descriptive analysis hopefully gets away from that some because they're just watching and recording. Sometimes another disadvantage of the descriptive analysis is people will write down what they see, but what they see is not what is maintaining the behavior. And an example would be is if I was scratching chicken pox and staff came over to me and said, "Oh, Susan, don't do that. You're going to make your arm bleed. You're going to get scars." If somebody was doing a descriptive analysis, they're probably going to write down, "Susan got staff attention for this." But we probably can all relate to, I might have been scratching because it felt good. There was another variable that they couldn't see. So we got to keep that in mind. The last type of functional assessment is what's called functional analysis. It's sometimes called the gold standard, although it has limitations too. I think especially in people who are have language developed. It might be used in a counseling session, but it requires a lot of training, even to use a functional analysis with people who don't have language developed. It is suggested that there's like a doctorate level person overseeing the analysis, whether they're there in person, they might have coached somebody, they might have the parents or the staff wearing earbuds and they're coaching them that way. But I'm going to say it's not going to be used near as often by most people in HCBS waiver, but it is out there. Next slide. Okay, so treatment rationale. I want to say not everybody's going to use this. So it might be optional. I don't always put it in my BSP, but I kind of mentally do it myself. And what it is, it helps explain how the treatment strategies are function related to the behavior. Unfortunately, sometimes I'll see somebody has like a behavior of concern that's elopement. But when I look at what new skills they're being taught, to brush their teeth twice a day, or to clean their room, or to balance their checkbook. While there's nothing wrong with those skills, they're not functionally related. So this kind of helps put this all together. It helps explain why this new skill is being taught and how this strategy staff are doing are going to, dovetail with the person's values and minimize their need to engage in that behavior. Next slide, we have an example of a treatment rationale. And that would be Mary values relationships. So I want to keep in mind what's important to her. The second bullet is, but when she engages in vocal aggression to other people, that's a barrier to relationships. So I think that's really important right there. I'm not saying I'm treating vocal aggression because I don't like it and it's not what I don't want to see happen. I view it as how that behavior is a barrier to what's important to Mary. And my assessment, well, it says that vocal aggression is most likely to happen when she feels like she's being told what to do. So what I'm going to do then is first, I'm going to have staff try to give her a lot of choices. That's something staff can do. And I think there's one more bullet, Courtney. And also for a new skill for Mary, I'm going to teach her a new skill, how to self-advocate. She can say things like, I don't like it when you boss me around. So there's one thing Mary can learn there, and there's a staff strategy, and both of them are intended to decrease vocal aggression, which is going to help Mary get closer to what she wants. And they're both represented or the results of my functional assessment. That's kind of what I do in my mind when I do a treatment rationale. Next slide. So let's talk about some proactive strategies. And I think this is one of our objectives too. We want to look at the difference between the two of them. These are things that staff or parents, if the adults, can do to avoid the interfering behaviors from happen. And it's really important, I think, that we really focus a lot on proactive strategies because it can avoid the behavior of concern from happening at all. One thing that I like to always include is kind of a listing of activities or item that the person enjoys. So like if I had done a preference assessment and I know that they like horses and I know that they like football and I know that they like playing basketball or a certain kind of music, I can put that here because having, assisting them and coming into contact with the things they like and talking about the subjects that are valuable to them, it's going to form a lot of relationships and that's going to make them happy. So that's a really good proactive strategy. Next slide, please. So let's look at how some proactive strategies would look. For David, who we talked about. This is the person who had the transfers, who didn't have language and didn't like being transferred. So these are just, ballpark examples. for one thing, we can continue to explain transfers before we start the procedure. So don't take him off guard. He knows what's coming. We can reassure him that we're going to keep him safe. It's possible that sometime in the past, David was dropped or experienced some sort of distress during this transfer, and that's why he dislikes it. So I want to reassure him of that. We can link it to something that he values. Like, as soon as we get this done, we can go to play bingo or whatever it is that he likes. And we can also just make it less aversive by, if we know he likes singing, we can sing during the transfer. That will be kind of a distraction that just might be what we technically call change the function of the antecedent. So when the antecedent is a transfer, and historically it's been something he don't like, it's aversive to him, and we're trying to change things so that the transfer isn't all that bad after all. And I throw that terminology in there because we often hear function of behavior, but we as a field, we're not talking a whole lot about the function of the antecedent. And that's something we should probably get comfortable with too, because it offers a lot of good strategies that we wouldn't want to overlook. So let's go to the next slide, and now let's look at some examples for David that we could use for him. Oops, I beg your pardon, for John. I used the wrong terminology. So for John, what I like to do is go back and look at, in the functional assessment results, look at the antecedents and see if there are things in there that I can address. So he doesn't like being bossed around. Well, then let's try to find ways to make him, reassure him that he's in charge. Ask before we enter his room. Ask before we take his tray. If there was an issue with him, he thought somebody picked out shoes without asking him. So use all those examples that are going to address the antecedents that are in that box. And avoid any words that's going to make him feel like he's being treated like a child, because that was something important to him. We can ask him what he needs. Is there something that I can help you with? Is there anything that you need? I just want to be cautious that when we ask a person like that, we always want to do it before the behavior happens. If the behavior is already occurring, he's already yelling out at people, and we ask him then, what do you need? I'll get it for you. We do run the risk then that he will continue to use that behavior to get those needs met. If somebody says, here, have a cookie and calm down, then that's become a good way to get a cookie. So asking the person what they need before the behavior in an antecedent strategy can be very, very helpful, but be cautious about doing it after the behavior's already happened. Next slide. Okay, so now we have I think about 5 slides on restrictive interventions in BSPs. We want to make sure that you understand the rules and regulations with implementing something restrictive in nature. I'm not going to read through all of these. They come through the Iowa Administrative Code. I understand that there is a link there that you can click on, and you will go directly to them. Most of these things, I'm hoping that you're already familiar with them. I'm going to say that if you have questions on any of them, that's something, or you want more information on them, put that in your survey results or in the chat and let us know. So why don't we go, unless you think we need to read through them individually, Courtney, why don't we just kind of touch briefly? It looks like there's definitions on restraints and what is a right restriction, the definition of a behavior intervention plan. And it looks like these have been in place since July 2018. So 3 years plus.
Yeah, I don't need to really add on anything, but if you have any technical assistance needs, let me know, or reach out to your HCBS specialist. That would be a great point person for any of this Iowa Administrative Code reference.
So thank you. So now we are what ITABs, or what I would like to say about restricted procedures. And I think that my background is trying to also make this align with like the literature of human rights committees. And I know that that's not relevant in an HCBS setting. I have worked a lot in settings in which it is. And so that's kind of my go-to. And I don't think if it's a rights, issue for people in one setting, I think it's something to consider for the other. And I think it's very consistent with what the Iowa Administrative Code said. But if a restrictive procedure is in place, we should consider them to be temporary while the person is learning new skills that's going to reduce the need for the restricted procedure. So say, you know, you have to like lock the refrigerator or lock the house or the window or something like that temporarily. You can't just lock it and say, okay, now we don't have to worry about that anymore. It's locked up. It can only be temporary while we get to the bottom of the issue of why the person, you know, is trying to get in there or seek food 24 hours a day or crawl out the window, and that we learn new skills so that they don't feel the need to resort to those behaviors that have been behind the restricted procedure. We should always describe what the restricted procedures are in the BSP and provide directions for using it, or explain where it can be found. Like I've seen people who, you know, had sharp objects removed, you know, following for a period of time following suicide threats. So you're going to have all that information on what to do about it somewhere. And every situation is different. One thing I don't know if I said in the beginning is when ITABS writes a BSP, you know, I write for a variety of different settings, home settings, you know, HCBS settings, and also, you know, ICFs and shelters and various places in between. I never know what it is, so I try to write it generally enough that the facility themselves will have it what they need to do. Because if I write it for somebody and they're in one setting and 3 weeks later they move to a different setting that has different procedures, I have to be careful that I don't, you know, just restrict it to any one location. So next slide, please. We have some examples of restricted procedures, you know, bedroom windows covered with a shaded film. I remember that for somebody who enjoyed doing a striptease for a neighbor. And, you know, staff really couldn't constantly supervise this person while they were in their bedroom. So had to, until that behavior, we found strategies to minimize that behavior from happening, had to cover the windows with a shade of film so they could, so that the neighbor, you know, wasn't complaining about it anymore. But you can see a whole list of things here, including medications locked. And I think there's a couple more bullets. Social media restrictions, see, you know, especially a lot of people who have limited or supervised access to phones or tablets. Money management would be another one for people who have help with that are not able to manage their own money. There's a lot of different examples. Those are just a ballpark example. I will say one thing is that sometimes when there's a restricted procedure, it's easy for staff to kind of get relaxed on identifying the skills and supports that would you know, discontinue the need for restricted procedures. It's kind of like, oh, that's taken care of for right now. And that's one thing that, you know, you want to really keep up on, you know, what are we doing? And another thing I want to say is the word temporary, while that is what the Human Rights Committee literature says, people hear temporary and they think very, very short term. Sometimes temporary turns into very long term. Sometimes people like maybe have some sexual offending, a threat of sexual offending. You can't just do a program for 3 months and then say it's over with. Until you feel the threat of safety is gone, it might have to keep going. But that doesn't mean you don't have to continue to try new strategies and teach new skills in that meantime, even if the interval of time turns into a very long period of time. Okay, next slide. So kind of a recap. Restricted procedures should not be used as punishment. They should not be used as staff convenience, and they should not be a substitute for active treatment. They should be used to keep the person, other people in the environment safe while the person is simultaneously learning new skills to reduce the need for the procedure. And I think that if we get into a situation where the individual cannot learn new skills, like I mean a current official diagnosis of dementia or another type of neurocognitive decline, you know, that's something then that you would want to have a lot of discussion about on how you're going to handle it. It may actually turn into less of a restricted procedure and sometimes what's considered an EMOD or an environmental modification is to keep the person safe. but that's probably a thorough discussion, and that's probably beyond the scope of this presentation as well. Just wanted to throw that out there, that I do recognize that sometimes it is going to be very, very difficult. Next slide. So I also include in the BSPs new skills that the person is learning or that I think would be valuable for them to learn. Sometimes these are skills that are learned in a counseling session. Sometimes they're things that staff can kind of expose a person to in their day-to-day interactions. Sometimes modeling the skill. If staff model the skill for the person, that's going to be way more effective than sending somebody to therapy once a week or once every 2 weeks. So I like the staff to know what they are. And if I would never put this many probably in one BSP, but it would be something that I would talk with the team about and explain it. I don't write the complete directions out in the BSP, but I would want to note them here because I think that this kind of fits my treatment rationale too. This is what I think the person could learn, and that would help minimize their need to resort to those behaviors. Obviously, communication is important, and even if the person has vocal skills, teaching self-advocacy skills that are appropriate to the context or the situations, very important. That's what a lot of aggression is, or a lot of vocal aggression, when they're lashing out at other people. There's other things that they can do, like saying, I don't like it when you boss me around. That might be better than threatening to, hurt your children, tonight when you're not watching, that type of thing. Delayed gratification is another one I get a lot. People can't wait. Relaxation, emotion regulation. What I can and cannot control, and getting unstuck, self-compassion. Those are clearly ones that are more related to people who have language involved or developed. And, they're beyond the scope of this presentation, but I am putting together a shorter presentation to cover some of those kind of like therapy-based skills. If that's something that interests you, you can put that in your survey, or if you want, you can contact me directly. And we can talk more about this, because I think that there's a lot of need for those with the people that I see in consultations. So next slide. Oh, the desensitization to medical procedures. That's really important too. Those would actually be skills that would be great that would help people very early in life. I encourage families that have children with autism, I encourage them to start those at age 4, get out of the bathtub and start getting used to having a tongue depressor and, something looking in your ear. Because when people are desensitized to medical procedures, it's going to result in them getting better, more inclusive medical care. If they are scared to go to the doctor and they cannot tolerate something like an X-ray or some sort of a procedure, that's going to have an influence in their health throughout their life. So desensitizing to it early on, even as a proactive strategy, I think is really important. And sometimes, we don't address that until there is a medical issue, and then the person can't tolerate the procedure. Next slide. So let's look at the next slide, some new skills here. We have an example. We're going to go back to John. He was the person who, had a lot of vocal and physical aggression. So for him, he might be a really good candidate for teaching self-advocacy skills, because that's basically what he's doing when he's yelling at people and throwing things. He's advocating that, he wants control. He don't like them talking to him the way that they are, because he perceives it as they're calling him, they're being disrespectful or treating him like a child. And staff could even provide a prompt, hey, if you're angry at me, you can say, I don't like it when you, and then fill in the blank as to whatever it's appropriate. But I think we would all respond better for him to, even if he yelled it, I don't like it when you come into my room. That would be better than him throwing something, at somebody else or whatever the situation might be. And then we can always work on changing the tone of voice. But the first step is to get him to use that new skill. So that's one example of what that could look like. Let's look now at the next slide. And while we've been talking about proactive strategies, we're going to shift gears here. Proactive strategies are the ones that happen before a behavior has occurred. Now, when we talk about reactive strategies, we're going to talk about, things that we can do once we see either the behaviors occurred, or even when there's an early warning sign or sometimes just warning signs. Those are things a person can do. These are things that the person does that signals that one of these behaviors may be about to occur. I want to make a distinction here. When we had functional assessment results and we talked about antecedents, what happens before the behavior, those are typically environmental things, like the room was really noisy, staff asked him to make his bed, things that are more in the environment. An early warning sign is within the person's body. So like pacing, maybe the person starts mumbling, "You can't make me." Very common, people have dilated pupils. Sometimes we're not close enough to them to see it, but sometimes we can, we are, and we notice that. And sometimes staff will say, "Oh, he gets this look in his eyes." So early warning signs are things that are within the person. And then in the behavior support plan, well, let me say that what's really valuable about having that in your BSP is that it gives staff a heads up that, whoa, something's brewing here, and this is my chance to step in, with a therapeutic intervention to avoid the behavior from happening. So, I would want to know it. If I was the staff, I would want to know what to keep my eye open for and what it might mean, so that it doesn't continue to snowball into a bigger issue. And then whatever the staff should do, and that's very individualized and personalized. It might, there's a variety of things that it could be, but I would list that. Let's go to the next slide and we'll look at an example for David that we talked about. David was the person who did not like to be transferred. So next slide, please. Oh, there we are. I beg your pardon. I looked down when I seen it. I apologize for that. So for
Sorry,
David,
I'm a little delayed too.
that's okay. It might be to validate his feelings. We cannot, like if he's letting us know that he doesn't want to be transferred, unfortunately, we can't stop transferring him. He would have bed sores and a variety of other things. So for David, one thing we can do is, we can validate his feelings. "I know you don't like being transferred, or you don't like being transferred, do you?" And I can reassure him, "I'm sorry, I'm going to do the best that I can. I'll make it go as quick as I can." So those are things that when I see David start to, exhibit some early warning signs that I could do for him. Let's look at what we might do now for John on the next slide. John is a little bit more complex because we can possibly stop the behavior. These are just general examples. First of all, we should ensure everybody's safety. So if there's somebody who's really vulnerable close by, we want to try to create some distance between them. For John, we know that he does not like to be touched at all. And for John, we cannot touch him. David, we couldn't help it because we have to transfer him. We have to. But with John, we have an option there of we don't have to put any touch on him. It actually escalates him even worse. We can validate his perspective. We can encourage him to use those skills that he's learning. Hey, when I'm mad at somebody, I tell him, you can tell her that you don't like it when she, blah, 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 whatever it is. So encouraging him to use that skill. And when staff do this, I call this being the bridge between the therapy session and the real life situation. And a lot of times what I'll hear people say is, "Oh, she can talk about those skills when she's calm, but she can't use them, in the heat of the moment." The finger comes back to us. We have to be that bridge to help the person use the skill. They may not even think about it at the time. And we can prompt John to get back on track. It's important that we use a gentle and caring way of doing it. How can I help you? Can we get back to blah, blah, blah? Can we do it together? Notice the we, that's a collaborative approach. A lot of people, they like that, knowing that you're part of the team. They're not alone. You're with them. Can we do it together now? Whatever it takes to get the person back on track. You do want to be careful after the behavior occurs that you try, if at all possible, you try not to provide the same payoff that was identified in the consequences. Let me give you an example that would be relevant. Let's just say that if somebody enjoyed the emotional distress that they saw in staff and peers when they were yelling at them or making threats, like if somebody went, "Oh," or that's not nice. You shouldn't talk like that. Then to display that same type of emotion, it could actually be strengthening the behavior. So we want to try to withhold that just in case that's the payoff, if we think that that's the payoff. So that's probably a more detailed, there's probably a more detailed explanation. We could go into that. There's so much variation, but I just want to say, keep in mind what your consequences were in your functional assessment, and be careful that you don't inadvertently strengthen the behavior, if you can help it. Sometimes if the person's safety is jeopardized, if somebody's out in the middle of a road, or they have a knife to their throat, you've got to do what you got to do to keep people safe. So there's no one answer to tell everybody, but just to keep that in mind. Okay, so the next slide, we have 10 minutes left, so we better keep moving. Some generic examples of reactive strategies, what staff can do when that behavior happens. First of all, I often, in my BSPs, I often say follow facility guidelines. And that's because, some facilities train MANT, some train CPI, some have a different strategy of their own that I don't even know what it is. And I don't want there to be a discrepancy between what their staff has been trained to do and what I tell them to do, because that's going to be confusing and it's going to set staff up for failure if they have two different sets of directions. But in general, if you are writing for your own facility, it's really important for staff to know to stay calm. Not only their emotions, but also their facial expressions and their body position will influence the person's. So if they look frustrated or have their hands on their hips or something like this, or if they look scared, that's going to influence the behavior. If somebody likes to intimidate staff and they like to feel powerful and they want control back, and they find that doing this type of thing makes staff cower, by golly, that's going to promote it. So stay calm and let your demeanor, that's not to say you shouldn't be vigilant and be aware of where you are physically, so that if there is a dangerous situation, you can protect yourself, but don't don't give any hint to the person that you're scared or upset, if at all possible. Ensure safety of everybody in the room, especially if there's people who are physically vulnerable. And another good idea is just try to create distance between the individual and anybody who might be a target. That might be saying, Sally, why don't you and I walk back to a quieter area where we can talk more about this? You can't tell somebody that you have to go to your room. That's a restricted procedure, but you can invite them to go to a quieter area or somewhere else. And in doing that, it'll create some distance between them. Sometimes a solution would be for the other people to move. You can encourage them to take some big breaths or sit down. The advantage of sitting down is people's nervous system actually de-escalate. And if they are sitting down, you want to get down so you're the same level, you sit down too. But if they're sitting down, it gives you just a little bit of a warning if they are, say, an elopement risk, or if they have physically aggressed other people. They're going to have to stand up first. So it gives you just this much longer to prepare for that. And you can ask what you can help her do to work toward her goal. So notice that's not saying, what can I do for you? That's saying, hey, I know that more, independent time is important to you. What can I help you do right now? What choice can I help you do right now that's going to help you work toward that goal? So it's reminding them of the goal, not just saying, what can I do right now to fix all of these problems for you? Okay, next slide. A couple other things we should consider in BSP development, and that is some sort of a data collection system. Again, sometimes that will be depending on if you're using software, it might be something staff enter into a computer or a tablet. I've seen staff that have a one-page piece of paper that they call data sheet that they keep in their pocket. And then they enter, as things occur, every hour they bring it up to date. And then at the end of their shift, they add it into a computer system. There's a lot of variation there, but the important thing is to have some sort of data collection. Without it, we're relying on subjective reports oh, things have gotten worse. And what we know is subjective reports really aren't as accurate as objective data. So one of the reasons we want to do it is to evaluate the rate of behavior And also, I should have put a comma here to say evaluate the rate of behavior and also the rate of behavior change. When I say rate of behavior, sometimes people will report that something's happening a lot. But when we do a baseline, we find out it's really not happening to the extent that they indicated it was. But we want to look at changes too, especially and line that up with interventions and see, well, when this intervention started, then how did the rate of the behavior change? Okay, so we need the rate of the behavior, and we can use that then to determine whether or not we want to continue interventions, including like medication or restrictive procedures. If the person hasn't engaged in the behavior that kind of triggered the restrictive procedure, we may not need to continue that. I mean, it may have been a year and a half since that behavior happened, but yet we still have the restrictive procedure. And so we have to do kind of like a risk-benefit analysis. So evaluate the rate of behavior, determine the need for interventions, and let's go to the next slide. A third way that data collection can be helpful, it will help you identify any potential trends. Sometimes we see certain times of days or days a week or specific staff that are working or are not working or always during an outing or whatever it might be. But when we see that there's trends there, that gives us a lot of information on what we can hone in on. When most people are gathering data, I should say they're often going to use a frequency measure, like frequency of instances or episodes. Data collection could be a whole nother presentation because it does get pretty complicated when we talk about dimensions of behavior. I want to suggest that you at least consider taking data on any behavior for which psychotropic medication has been prescribed. An example that I've seen is like somebody's maybe taking trazodone to help with their sleep, but nobody's measuring sleep. So how is the prescriber supposed to know, is this helping at all? Is this the right dose? Because if there's no data to report to that prescriber, you know, it's just hard to imagine how they could possibly be making a database decision. And that comes back to us in terms of keeping the data and doing it. Okay, next page. Real quick, like I'm at 12:56. So talked a little bit about data collection to evaluate the rate of change. These are beyond the scope of today, but we should also consider competency-based training. You really have to do a good job of training the staff, and that not only talking about the behavior support plan, but do some role modeling, show them what it looks like to do the strategies, and then do reverse role playing. I'll play the role of the individual that's receiving services, and you play yourself as the staff. And I'm going to do some of the things that person does, and let's see if you can follow the BSP. Sometimes you identify a lot of misunderstandings there. And then there's also procedural integrity checks. So even after I've trained on it, and then I probably want to follow up like within the next few days or week or so and make an observation and seeing if it is being implemented as it's written. Sometimes staff don't have the materials that they need to do it. Sometimes they don't understand it. Sometimes they do. And, for their own, for a reason beyond me, they're choosing not to. They might not agree with it. They might think that they have a better solution. We should use the data to make decisions. So when we do that quarterly review, or as often as it's reviewed, that helps guide us. And we really should make those decisions based in data. And then the last idea is peer reviews. And that's when you're really struggling or the person's struggling and the team is struggling to come up with ideas and strategies that'll be helpful. To use a didactic copy, depersonalized, and have someone else within your facility, maybe a different team, a different pod, look it over and give you feedback. Like, what do you think would happen if you tried this? Have you thought of that? Has this ever been tried? And to also recognize, so to give you a lot of new ideas and also recognize the things that maybe somebody in this pod, overlooked. And we can gain a lot from each other. Nobody has all the answers. And so having a peer review the programming can be really helpful for the person. So that is the end of the presentation. We have a few minutes for questions. I don't know, Courtney, if you want to recap. I haven't really been reading the chat. I see there's some in there. Is there a way for you to summarize or to fast forward to what you think? Okay.
Yeah, I just have two questions. So one question was around, are there behavior support plans, I think, or child-based, they were asking, are there ones that are preferred for children? And it was back at the beginning of your presentation. Katie, if you want to unmute yourself, Katie Hansen.
Yeah, just more with the evaluations piece. If there's any preferred for school-age children.
Do you mean assessments? Is that what you're referring to? Like the functional assessments?
Yeah,
I don't know that there's any specifically for children. I guess that would be a good question for the AEA. However, when I see like IEPs that obviously are doing functional assessments for children, they often use a functional analysis. I think any of those that I mentioned would be applicable. I know for myself, if I am considering functional assessment for a child who's had a very, I'll say, colorful childhood and adversity and, possibly some trauma in there as well. I take that into consideration when I'm doing the functional assessment and ask specific questions about that. But I am not aware of any like functional assessment that's specifically just for children.
And then the next question was, would there be a good resource for people to use in training staff to assess the intensity of a behavior more uniformly?
Is there a resource for the intensity? Well, I think you have to start, but by the way you define it, like SI, self-injurious behavior is fairly common for that to have different intensities. So you might have somebody who's like maybe picking at skin a little bit. That's a lot different than when they actually open a wound and it bleeds. Sometimes with like their hand coming into contact with their head, they'll say soft head hits are level 1, but really hard ones, and they'll define it in a way. So I think that it comes down to how you define what it includes and what it doesn't include. There might also be like leaving assigned area versus elopement. So I've seen like different, if you call it intensities, does a person not stay engaged with the task and they go somewhere else in the room? Do they leave the room but they stay within the building? Do they leave the building but stay within the property lines? Or do they completely, leave the yard? So it's all in how you define it. I would think if you have a specific example, you can let me know and I'd be happy to talk to you. Or if I'm not understanding the question, I'd be happy to talk about that in greater length.
We actually handle quite a few high behavior situations on a weekly basis at our agency. And so I'm doing ongoing staff training with that, Susan. And so my question was, you've spoken referring to some of the Department of Justice statements and guidelines and things like that. I just wasn't sure if there was anything in terms of staff training that does further delineate that out. But I'd be happy to have a conversation with you to figure out where we should train our staff to draw those lines in the reporting so that information is reported accurately later on.
In terms of the behavior, you mean being reported accurately?
Yes,
is that
correct.
What you're referring to?
Correct. The level of the behavior of our clients. And we're working with iStart, for example, and I want to be able to give them accurate information as to when someone's escalating a pattern of behavior. And so in terms of, I've got 120 DSPs who all have different perception levels. I can have one DSP see a situation and think nothing much happened, and someone who's newer to the organization thinks that was a horrible behavior. And so I'm trying to delineate the best way for us to standardize that across our DSP staff.
Yeah. And if you want to, you contact me afterwards and we can do a brief call if you want to for more examples. But I think a lot of it I'm going to stay with, unless I hear more, I think a lot of it goes with how you define it. And so aggression might not be defined the same in John's BSP as it is in Bill's BSP. So people see aggression, but we have to look at what that definition is for that person.
We also have an entire training on positive behavior supports that talks about how to define that behavior. It's a 4-hour training, so it goes more in depth, and this is to accompany that training. And so that might be a really great place to start, James, too. And that would be under our competency-based training. It's under the archive of previous trainings. And that can be at the link that I sent
Thank you.
Okay, and then a question about our agency has a human rights committee that reviews behavior plans. Is there anything that you would recommend that we always look for or watch for in this committee?
Yeah, there's a lot of things, and probably a good resource for you to look at is there's a small paperback. It's about a quarter of an inch thick. It's called Human Rights Committee for Individuals with Intellectual Disabilities. If I remember right, the author's name is Steve, and I want to say Tabor, but I'm not positive if that's the last name. But if you won't go on Amazon, you'll find it. There's two versions, and it's small, but it really gives guidelines for what they should be looking for. So what I've tried to do is flip that around. If this is what the Human Rights Committee is looking for, then this is what I should proactively be covering in my BSP and in my my presentation to the Human Rights Committee. So I'm like, beating them to the punch. I'm covering it all before it gets to the point that they need to ask me for it. But if you don't find that book, send me an email and I'll send you the actual reference to it.
Thank you for attending this training today, an introduction to behavior support plan development. This series of trainings from Iowa Medicaid will be based on gaining core competencies in long-term services and supports. Please complete this competency-based assessment shown on the screen here, either through the link or the link on the PowerPoint, or through the QR code to add this training certificate to your own professional portfolio. This competency quiz will be available as long as the training remains on the Iowa Medicaid website. Please allow at least 2 business days for your certificate to be delivered to you by email. You may retake the quiz as needed to get your desired score, and a certificate will be sent to the email address provided to us. We appreciate your virtual participation and welcome feedback. Please complete this survey here through the link or the QR code to give us feedback about this specific training and help us plan for future trainings. We appreciate your time and interest in this topic, and we look forward to seeing you in another training opportunity with Iowa Medicaid. Thank you.